who's there.
Who's there?
Oh, I'm sorry, it's nobody. I was seeing things. It seems like I haven't seen you in a million years, but I'm hoping you had a great time.
Yeah,
I also had a great time.
that's great.
I
Yeah.
know. Well, my brain is like, wow, wow, wow. It's a lot of information. But guess what? We're going to get some more information today.
All right.
However, very quickly, and with really deep appreciation, I wanted to welcome all of the new women that we do have here. Um, they don't really come up by name exactly, and so I really wanted to welcome all of the new women. Certainly welcome you. Certainly welcome the women and men who are going to be coming up, and just let everybody know that we're really very blessed to have our dear, dear Dr. Rosensweet with us always. And it's very appreciated. And I heard about that on my conference, by the way, at my conference. I did indeed. So I guess you're famous, and maybe I'm a little bit famous. And I'm fine with that. Okie dokie. So we're going to start with question number 1, which has to do with our favorite subject, progesterone, along with all the other favorite subjects we have. Woman writes in, as we get often, that she does not tolerate progesterone well at all. However, she was told by a few people, and I believe a doctor as well, to try progesterone oil sublingually, which would mean under the tongue. Wondering your thoughts about that.
Well, this comes up frequently.
I know.
Well, in general,
Oh,
most women, you'll have to mute, we're getting an echo.
okay.
Yeah. Most women tolerate progesterone beautifully. I mean, when you think about it, a young woman produces 100 times more progesterone in a month than she does estrogen. That says a lot about the value and importance of progesterone. So any woman who's ever menstruated, we know there was a time in her life that she tolerated / embraced / love progesterone. Hello. Your cat is so interested in menopause. I can't believe it. You're muted, so I can't quite hear you. But your cat is probably the most knowledgeable cat on the planet about menopause.
You have no idea. If he jumps on this thing, I'm going to kill him. He's not going to be a cat anymore. Come on, Beach. Anyway.
So just know every woman at some time in her life has tolerated progesterone. And there's a small percentage of women, I mean small, it's less than 1% in my experience, that don't seem to tolerate progesterone. And we're constantly trying to solve that individual woman by individual woman. And the question is, why are they not tolerating that? And I think one reason that I've sort of made a guess at is that progesterone can decline earlier and deeper than estrogen does. That's a very common experience for women. And so they lose a lot of their progesterone early on, not necessarily all of it. If they're ovulating, they're still going to be producing progesterone. But what I imagine there is their receptor sites to progesterone start toning down, start going dormant to the extent that their progesterone declines. That does not explain this unusual or difficult to understand lack of tolerance of progesterone. It definitely happens. Where I first saw it was in a woman who had a hysterectomy in her 30s. And I started treating her total hysterectomy. That means the ovaries were taken as well. And I started treating her in her 50s. And she had been on Premarin the whole time from the time of total hysterectomy. And I wondered, and she did not tolerate progesterone, topical progesterone. Finally, over the years, she's on a very, very small dilute dose of progesterone. So we're gradually waking that up. But very, very small topical dose of progesterone. And my picture there in her case was the number one, she stopped having any experience with progesterone, and there was no progestin in what she was taking. She was taking Premarin, not Prem-Pro. So my imagination with her is her receptor sites went totally dormant. And then Premarin can have some challenges with it. I'm well aware that the women who were treated with Premarin or Prem-Pro over years or decades, in general, they did a lot better than women who received no hormones at all. And much to the surprise, probably not to our audience so much because they've heard us beat the drum so long, those women who took Premarin and or Prem-Pro were at less risk for breast cancer, heart attack, and stroke than the women who did not receive any hormones back in the day. But there's molecules that are in Premarin and Prem-Pro that the female body has not seen. Half of the estrogens are horse estrogens, unique to horses. I don't know if that's relevant or not. If you find me wandering or a little baffled by this, I don't know why. Dr. Jonathan Wright has pointed out that there are women who become reactive or allergic to the bases that the hormones are put in. But that's a very unusual situation, I find. In the 15 years of using our organic oils, we've had 3 cases of minor rash, and we just switched to a different method. And I mean really minor, just a little, where they rubbed the actual hormones. And then since a woman is getting, in our method, 3 bottles, if she's tolerating the bias and the testosterone DHEA mixture fine, it's in the same oils mix. So it's not the oils. So is there a peculiar allergy or reactivity to the progesterone molecule itself? And you know there is. And Dr. Wright's lab, Meridian Valley Lab in Tahoma, Washington, I think you can send them in some saliva and they can test for allergy to progesterone. Is it worth doing that? Yeah, I think it's worth doing it. You know, we want to do is get on as excellent programs as we possibly can. And any functional medicine doctor who's really good at allergy and immunology, and the ones that are really advanced in that topic know how to desensitize a woman. So sending off a sample to Meridian Valley Lab, someone would have to call the lab and find out what the specifics of that were to see if you have a specific allergy to progesterone. Now, having said all that, when we see this unusual tolerance that a woman has, one thing I'm always looking at is the dosage, because a lot of women, when they say they're intolerant, they've been put on 100 milligrams or 200 milligrams of prometrium, and that's a micronized bioidentical progesterone. It's got other stuff in that capsule that I would never suggest anyone take, such as dyes and peanut oil. But at any rate, sometimes it's an overdose phenomena, because when we start women on oral progesterone, we start all of the women in the menopause method on topical progesterone. And we start with low doses. And sometimes women seem to need more progesterone than we can actually deliver topically. So what we do is we'll either switch to or just add in oral progesterone. And we start a woman on 2 different bottles. One of the bottles contains 50 milligram progesterone in capsules. A second bottle contains 25 milligrams of progesterone in capsules. And we'll start most women on 50 milligrams. And we'll have them do that for 3 nights and see if that helps them sleep. Those are very commonly the symptom that a woman needs some oral progesterone. And if they do well on the 50, the next 3 nights we'll put them on 75 milligrams. So there'll be one capsule of each, a 50 milligram and a 25 milligram. And if they do well on that, we'll increase them to 100 milligrams. We'll keep on jacking up that dose, otherwise known as titration, until a woman wakes up the next morning with symptoms of overdose. Since progesterone is so calming, if a woman wakes up over calm, i.e. groggy, and feeling like she's drunk or she took an overdose of a sleeping pill the night before, oops, too much, we'll back down by 25 milligrams, see if she tolerates that. So what I'm describing, yes, Carolyn.
So, well, what I'm wanting to know, because I know the question was like, if you put the oil sublingually.
Yeah, I promise to get there.
No, okay. I was just wondering, like, if that would be stronger because of the two veins that are down there.
Good point, but I'll get there in a moment. So what we're doing is sometimes when women say they don't tolerate progesterone, they've been on too high of a dose. And in my practice, women vary in general between 50 and 150 milligrams. That's what they like. That's what they test out at well. But occasionally there's a woman who needs less than 50, and occasionally there's a woman who needs more than 150. So sometimes intolerance to progesterone is that they're on an overdose. If a woman only needs 50 milligrams and 75 milligrams would make her groggy in the morning, you put her on only 2 commercially available progesterones, bioidentical, Prometrium. You put her on 100, that's the low dose, that's going to be too much for her, and she's going to say, I don't tolerate this. I'm giving you the various reasons why a woman would say, I don't tolerate this. And then sublingual. I love sublingual for nitroglycerin. It's fantastic. And I'm sure there's other things sublingual is really good at. But anyone who's ever stuck something under their tongue finds that they're also swallowing some of it. And we can't control that. So I am definitely not a fan of sublingual, especially since we don't need sublingual, because although I mean, you never say never in medicine, but topical in estrogen and testosterone works almost 100% of the time. And oral works with DHEA and progesterone. And sublingual is a mix, and we like to get very specific about the dosage. For example, for a woman in menopause, let's just take progesterone. I don't think it's good medicine to vary the dose of progesterone orally. Like some women in their process of figuring it out, they like 125 milligrams, but some nights they take 150. And they're playing with it. And I'm saying, I don't think that's a good idea, because better from my perspective, there's so many things that are connected to progesterone that we don't want to vary it. For example, progesterone affects estrogen working within estrogen receptor sites. We've been doing this so long, Carolyn, I see you internally smile when your knowledge base is like you're so familiar with some of these concepts. It's a pleasure to see that. We don't, and also progesterone facilitates the action of thyroid within thyroid receptor sites. So we don't, from my way of thinking, we don't want to have very progesterone, because we don't want any variability in thyroid or estrogen. We want at least estrogen and thyroid to be able to relax into the consistency of a stable dose of progesterone. I think that works best. You never say never in medicine. There's exceptions right and left. Now back to the peculiar sensitivity. If it doesn't fall into the overdose category, and it might fall into that hyperreactivity, immune system responding, and here's one more category: receptor sites in trouble. Uh-oh. Uh-oh. Dun, 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 dun. Do you remember Dragnet, Carolyn? Or are you too young? Not too young. um,
We
I,
actually watch it. We actually watch it like 4 in the morning on Me TV.
oh my goodness.
I know. Huh?
Nothing like 50s TV. I'm getting a little wandering this morning as I just got off a plane at midnight last night.
Oy.
And I came from an environmental medicine conference, and it was the updates on the effect of the toxicity on the planet Earth. And anyone who has studied their own health and what you need to do about it, you've bumped into toxicity. And oh my God, what's happened to the planet with the poisons that are out there and that we're exposed to. I don't want anyone to be alarmed. This is the life that we were born into, and this happens to be the circumstances of this lifetime. And there's a lot more deeper, more influential determiners of day-to-day life. Yeah, but look out for this toxicity. And, you know, a lot of this toxicity comes from dinosaur, bless their hearts. I'm sure when they were around, I mean, I remember when you and I were back there on the tundra and we got so good with dinosaurs, they considered us to be their friends, and we considered them to be their friends, if I'm remembering correctly. I don't remember. I'm not sure I remember having a pet dinosaur, Tyrannosaurus Rex,
I
but
do.
you do.
Yes. His name
Well,
was Rex.
his name was Rex. Well, you know, they perished and then they became our gasoline and our petrochemicals that are turned into fertilizers and herbicides and pesticides. Why do they turn into herbicides and pesticides? Because they're so toxic. You know what it takes to kill an insect? Bless their hearts. You gotta have something that's really poisonous to do it. So these are known as petrochemicals. And oh my God, this is one of the many pollutants that we have on this planet. And our exposure to petrochemicals is extremely high. And the remedy for this exposure is go through your household and get rid of anything that smells strong. If it smells strong and it ain't a flower, toss it because it's a petrochemical most likely. And wouldn't you know, of all the biological effects of the petrochemicals, your household cleaning fluids, your dry cleaning fluid, you walk into a mall, you smell stuff, the stuff that's detoxing from the clothes that you buy that aren't organic. Holy mackerel, our exposure is outrageous, not to mention the herbicides and the pesticides in non-organic food. That's a major source. Well, how do they behave in the female and the male body? They attach to the ovarian hormone receptor sites. They're called xenoestrogen, Xeno. Of all the places in the world, in someone's body, these petrochemicals could go to, they're going to the hormone receptor sites in your nucleus of your cell. Huh. So a lot of cases that are difficult to manage, one of the things that we come up with, and I met up with Dr. Brookson again this weekend. It was so much fun to see her. It's just amazing. And this is a world expert on toxicity and the estrogen and the hormone receptor sites. She wrote a book many, many years ago about this. And so when women have these peculiar, tough to explain issues with their hormones, we go down a checklist. Well, what could be messing them up? Why are they not easy to manage? rather than technically complex to manage? Well, I think of what I always think of when someone's not doing as well as they would like. They've got issues of nutrition. They've got issues of exercise, too much or too little. They've got issues of toxicity. Oh, here we are. And of course, the elephant in the room is the issues of the dysfunctional response to stress. I'm going to go back to the toxicity. So, anyone who wants to get healthy, face it, folks, you got to come up with a detoxification regimen. And this conference I went to, they had some of the finest detox stuff out there, including a portable infrared sauna, which I have up in my bathroom. It was $350. Why did I invest in that? Because I know that that's part of my project, is to heat myself up. Because when you do so, these chemicals, these petrochemicals, they get liberated and they come up out of their fat storage depots, because that's a lot where a lot of them are stored, and you can sweat them out. Or they'll also, once they're liberated, you can also pee them out and poop them out. So there's a lot of techniques for detox. Ask a simple question, Carolyn. It's happened once again. A simple, innocent question about progesterone. But I think it's very important that we all think about this, because our exposure, even those who have led the cleanest of lives, is rather dramatic. How
Well,
much
dry cleaning. I mean, people take their clothes to the dry cleaners, right? All the time.
That's a big one. And there's hundreds of them. I mean, if you could go through all the bottles and the laundry detergents and the dishwashing detergents, and if you examine the labels on there, I mean, what do we got it down to? Distilled vinegar. This is what I like to clean with. Distilled vinegar and water. Cheap. Look at the money you'd save without all this crazy stuff that people are fragrance emitters, Glade, or excuse me for mentioning a product. So why am I saying this? Because this is the list that we go down when someone's not, quote, tolerating something. Is a woman's receptor sites having trouble? Now, it's like everything else in menopause and everything else in medicine. The process of discovery is always the same. We pay very careful attention to a woman's personal medical and health history. We'll get the clues about where the action items are. And if someone's had heavy exposures, and the list of healing, detoxification is going to be moved to up right near the top. So I may not have named the questioner's exact issue, but I don't think the solution is necessarily sublingual. But the final thing I'd like to say about that, even though I've never prescribed sublingual progesterone or sublingual anything, because of the mixture of some of it goes through those two into the submucosa underneath the tongue. It's a great place to absorb nitroglycerin. It's a great place to absorb anything you stick under there. It goes right into the bloodstream. Although I've never prescribed it a lot, because a lot of it goes down, gets swallowed. This woman, in her life, came up with a solution. Someone suggested a solution to her called sublingual progesterone. So I tend to be sort of fascinated by those individual creations. So I'm not going to dismiss sublingual progesterone. I'm going to say, try it out. Because it came to her. Someone communicated to her, try sublingual. Well, how does that magic take place? It didn't come to you. No one walked up to me lately and said, try sublingual progesterone. But it did happen to her. So I tend to be fascinated by the magic of life itself and the information that we get. So my final answer to this woman is try it out. There's no harm. You're not going to harm yourself with progesterone. The more the merrier. So what if you swallow a bunch of progesterone in a process and only part of it goes in sublingually? Well, you could. It's like drinking spirulina shake. You could drink a lot of spirulina shake in a day, every day for the rest of your life, and it's very unlikely it's going to harm you. We could drink a lot of progesterone, and it's so good for you that if that works for you, bless your heart. I love it. Do it. So, thanks for the question, Carolyn.
Well, thank you for the answer. Okay. Well,
Sal, Gwinnett, Jan, Haya. Good to see you.
hi
Antoinette,
everybody.
you are such a frequent flyer. It's good to see you.
Aw, aw. So, okay, and Sal and Antoinette. Um, this woman, am I outgoing?
You're good.
Oh, crazy. That wonderful. I used HRT for 15. It's called 15, not 15 years. I am in surgical menopause, and in 2018, I got thrombophlebitis. So they stopped my HRT cold turkey, just done. Finally, I found a naturopath who put me on a biased 50-50, but I struggled with low um, estrogen, and I was switched to another type of estrogen. Now I'm getting leg cramps. I do great with bioidentical hormones, but not chemical estrogen. So, do you have any idea why this might be, doctor? I'm wondering if maybe it could be the fillers that are bugging me, or maybe it's the higher amount of estrogen. I don't know. I'm confused. And that is her question.
I think there's a certain large number of women, probably the majority, that you could go to any healthcare provider that has done some studying and has some experience in treating women in menopause and do really, really well. Because as many moving parts there are, a lot of women do terrific just taking estrogen, progesterone, testosterone, and DHEA. And it isn't challenging and it's pretty easy. We've got to remember that prior to 2002, we're still getting a little bit of an echo there, Carolyn. Um, Prior to 2002, there were 18 million American women. 40% of the American women in menopause were on Premarin and Prempro. There was only one or two doses of these things. And most of these women did terrific. And you could see the difference and they felt the difference. So it wasn't this huge rocket science where you had to get highly technical with it. There's a lot of forgiveness. There's a lot of getting in the ballpark and you're going to do well. I don't want to overcomplicate this. Now, there's another side to the story. Once someone gets super interested in treating women in menopause with bioidentical hormones and focus their career on that, we have a different experience. We encounter the individuality of woman to woman. And same with men, we look the same, we're walking and talking, but biologically and in our consciousness, there's a wide range of who we are and what our internal chemistry looks like. So, for example, in the world of estrogen treatment, we know the average dose of biased that a woman does well with. In my practice, it's just for a number, it's 1.7 milligrams of estradiol equivalent per day. That's the average. But the range of women who do well is anywhere from 0.8 to 2.6, and there's even outliers above 2.6. That's a wide range. That upper number, 2.6, is over 3 times what the lower number is. That's the amount of variation there is women to women. Where they land within that spectrum is based on where they feel good and where they test out right. We test them with 24-hour urine hormone testing when their dosage is stabilized. Wide range of individuality. And you think about 4 different hormones, or probably 5 when you throw in thyroid. And they can vary as to the amount of estrogen, testosterone, progesterone. So the variations woman to woman are just infinite almost. That's not a problem at all. So all we do is we start with each individual woman, and we start out with low doses of each one of those, and we gradually increase each dose. And as we increase each dose, we're alleviating in most women symptoms of insufficiency. And if we go too high in one of the hormones, we're going to get symptoms of excess. So we back it down. And Carolyn's, you've downloaded, or you've put up on the Facebook Live the symptom list. And of course, there's a new edition of the book, and we've got to get that to you. And I want you to contact Sherry if you would. Just a logistic note there, and we've got a new PDF. We just edited the book, and so wide variation there. 1 or 2 doses of Premarin, Prempro. No, there's no testosterone in any of that. All the way to highly individualized treatment programs. And when a woman's having trouble, and the way this question was phrased, Carolyn, bless her heart, she may have a wonderful healthcare provider, but there comes a time, like I could, as I've said many times, if someone fractured their arm, I could set that arm because I was taught how to do so in medical school. But I'm the last person in the world, in the medical world, anyone who fractured their arm. Orthopedic surgeons have a level of expertise. They know so much that they know the details of how to put that arm, how to set that arm, so when the cast comes off, the person's got a functioning arm rather than just an arm that looks like an arm but doesn't work anymore.
So I'm not gonna send anybody to you.
Yeah, in case you were thinking of it. Yeah, so it's the same is true in menopause, because we're talking about treating a woman or a man with the most powerful biochemicals that exist in the human body. There's tremendous variation individual to individual. So when anyone's having challenges, I'd say there's a job. You've got to go from a wonderful healthcare provider that you love and is kind and has an interest to someone who's specializing in this, and they've had deep training and a lot of mentoring. For example, the physicians and nurse practitioners and prescribing compounding pharmacists that are in our program, they get deep training plus ongoing mentoring, including grand rounds, an hour a week, to discuss challenging cases and sometimes individual mentoring on their tough cases. It's like residency, which this wheel has been invented on how to train experts. And the medical model of it is terrific. And so there was enough in the question to make me realize there's some fiddling around here going on. And we never prescribe 50-50 out of the gate, because we find that most women do better on 80-20 biased, 80% estradiol. There are some women we do switch to 50-50, but only when we're looking at a 24-hour urine hormone test. Now, I never want to diminish the intuition of a healthcare provider. Sometimes you're sitting in front of a healthcare provider, they've got a lot of experience, and they go, I get it, I'm going to prescribe 50-50, and they don't necessarily know exactly why, but they get it in their bones, and they're right. So I don't want to immediately discount that because the medical profession, like every profession, it's sacred. And for the wonderful, blessed physicians and nurse practitioners and all up and down the line in the healthcare, so many of those folks, it's a dharma thing. It's in their bones. And so when you sit in front of somebody and they say, this is the prescription, they may, I've had things come out of my mouth. I didn't even know where it came from. It was like, who said that? I didn't know that. So I don't want to immediately dismiss the estrogen prescription. But when the questioner is saying, I don't tolerate it, we want to really zero in. And in situations like this, we start from scratch. We have a 12-page questionnaire that women fill out. We get the clues from the questionnaire. We do some testing. There's always a reason why someone's ill, maybe 1,000 reasons. So that's part of the great Sudoku puzzle of the planet Earth. You just lean into it and you figure it out. So now, thrombophlebitis. Good she mentioned that. We know that women can develop thrombophlebitis from hormones. And where did we learn that? With the birth control pill. There were a certain small percentage of women who were on the birth control pill, they got a clot in the leg vein and inflammation. Even more uncommon, in some women, that clot broke loose, traveled to the lungs or elsewhere. When it goes to the lungs, it's called a pulmonary embolus. Rare, but it happened. And so there's been a lot of investigation of this. And what everyone encounters who investigates this topic is it's from the oral estrogen, when you take estrogen orally. And the medical literature says it doesn't happen when you take estrogen topically. Oops. You never say never in medicine. So I remember Denise and Nancy. This is 28 years of treating women in menopause. I remember Denise and Nancy. I put them on my usual topical regimen of Biest and progesterone. And those two women, out of hundreds and hundreds and hundreds, said, gee, I'm starting to get uncomfortable in my legs, like when I got a clot in my legs when I went on the birth control pill. And I'm going, what? This isn't oral estrogen. This is topical estrogen. Well, I did what we always do. I said, well, stop it. Let's see what happens. And we stopped it, and the discomfort in the lower extremities went away in both of them. And then I said, let's start it again. We're paying close attention here. And one of the two, Denise, she redeveloped the discomfort in her lower extremity, and we even went so far as to get an ultrasound, and it turned out it was not a clot. And both of these women went on through gradual, starting low and gradual increase. Both of them wound up on topical. But it alerted me to be cautious and pay attention and never say to a woman who's getting pain in her lower extremity that it's not from the topical. Now, there's a couple reasons why. One thing I don't know from the questioner, when she got her clot, when she got her thrombophlebitis, was she on oral HRT? I mean, HRT happens to be always almost synonymous with I took it orally. So that might be the key to the highway. Now I want to take a little bit of a non-sidetrack. I don't know if people realize that COVID got a certain percentage of those who got COVID into big trouble. And of course, maybe many of you even have someone that was dear to you that's passed away. It's such a universal tragedy, and I'm not going to go too deep into it. Tragic for a lot of reasons, because the world experts that I respect say, if you get COVID, treat it early. You're not necessarily treated at home, and treat it early. And there's a long list of things that people can do. And I think it's very important for you to encounter that list. And, we used to have first aid kits at home. And if there's anything that belongs in a first aid kit, there's a list of things that can address COVID right away, right out of the gate. And most people do super well. You know what I mean? You don't get sick and feel like something run over. But you get on it early, and most people are going to alleviate and not get into trouble with it. And one of the worst troubles they get into is, of course, the lung stuff. And if you wait too long, you get this very unusual but response in COVID. You get a cytokine storm. You get a storm of these biochemicals internally that are inflammatory. And at that point, what do? They trigger many things, but one of them is they trigger coagulation. So someone gets super coagulable, and when you hear about people in respirators in the intensive care unit, it's because they've got clots in their pulmonary capillaries. The blood is clotted. Well, we've known this for a long time. It just happens to be especially horrible with COVID. But for example, your coagulation process is one of the most complex biochemical, biophysiological events that takes place, because you've got to be balanced. You've got to be perfectly, don't clot too much, don't clot too little. If you're out there in the tundra and a dinosaur bites your thigh, you got to be able to clot. You can't you're going to bleed. But when you're walking around and you're not getting dinosaurs threats, don't you remember? We had to look around every corner. And if a bus was coming, we didn't want the bus to block the dinosaur view of the dinosaur. Oh no, I'm getting my history a little mixed up there, pardon me. So we want to be able to clot when we need to, but when we're just walking around, we don't want to clot too easily. That's called heart attack and stroke, or pulmonary clotting in the lungs. Well, it turns out the American population is skewed towards hypercoagulability. We're not perfectly balanced in general. Why in the heck is that happening? Because we're provoked into a hypercoagulability. And one of the provocateurs is if our immune system is not quite keeping up with the tremendous number of viruses and germs that we're exposed to. There's a primitive element to the immune system that fights germs. It does many things. It has the gobbling up cells that go, oh, there's a germ, let me eat it and destroy it inside the cell. White blood cells, notorious for chomping up these germs.
They're little Pac-Men.
That's right.
That's right.
Well, there's other mechanisms that disable germs, and one of the most primitive ones is to throw a clot around them. Disable them by throwing a clot around them. The flip side of that is, if you're exposed to a lot of germs, you can increase the propensity of your blood to coagulate. And that's one of the reasons that Americans lean towards hypercoagulability in general, because they're being provoked by infections they're not managing entirely. So we're a setup. So when someone has had thrombophlebitis in the menopause method, we sometimes start evaluating their coagulation. And there's sophisticated ways to do that through blood testing. And our physicians are trained in this. And you can get into some rather extensive and expensive blood testing to try and see if someone has an increased propensity to clot. So when someone says they had thrombophlebitis, we're going to do a small, medium, or large medical workup to evaluate. And even though the medical literature says the propensity, as far as ovarian hormones go, to provoke a clot is coming from oral estrogen, we never say never. We know we're sitting in a world where half the people who leave Earth do so by heart attack or stroke. And heart attack and strokes are really about the clot that forms in a coronary artery that has arteriosclerosis in it. Because that's a roughened surface and that's a trigger for clot. So we've opened up a big territory there. I don't want to overwhelm you. It all comes down to the same thing. When a woman's in menopause, we take an extensive medical history. And if we see some points that draw our attention, we attend. And we'll do the due diligence so that a woman, we evaluate her coagulation profile, small, medium, or large.
Which is
And,
the beauty of doctors. Thank you very much. They may not be able to set bones correctly, but if
yeah.
they like menopause, God bless.
And sure enough, this year alone, we've done that coagulation profile, and I'm talking about all across our system, and on at least 3 women that I remember their names. So it happens. It's rare, but we'll do the evaluation. Having said all that, did I answer that question, Carolyn?
No, no, I'm just kidding. Yes, you did. You did indeed. Um, you did indeed. Yes. Yeah. I don't know if I could repeat what you said, but you did. And we have like 5 minutes. So I'm going to save this question for a minute. And Antoinette is saying, what are some of the symptoms, as we're on this, of 50-50 overdose that may trigger an indication for an 80-20 prescription of bias?
Good question, Antoinette.
She always asks good questions.
Yeah. It's unlikely. There's things that can take place in the world of treatment of a woman in menopause where it doesn't work well and you get some pretty obvious symptoms. The difference between 50-50 and 80-20, it's so unlikely that you're going to get an identifiable symptom. And a woman who's taking 50-50, well, what do we know about that woman? Her prescriber has done some studying and has got some experience because they know the importance of estriol, and 50% of what's in that bias is estriol. So that prescriber has come a long way in the world of learning about and properly treating menopause. And, women did well on Premarin and Prempra. And the level of expertise and advancement of the science to make it to bias 50-50 is just ginormous. And it's so subtle that it's unlikely, Antoinette, that any woman who's on 50-50 is going to be able to tell the difference between 50-50 and 80-20. Now, having said that, there's some women who are on 80-20, for example, and they get wonderful symptom alleviation and they feel much better. And then at the 3-month mark, usually, plus or minus a month or two, when a woman says, I feel good, we test them with 24-hour urine hormone testing. And the level of biochemical specificity around hormones gives us the opportunity to copy nature. and take a look at the three estrogens, estrone, estradiol, and estriol, that show up in a 24-hour urine, and the estrogen metabolites, and we'll see maybe the 24-hour urine shows, yeah, the woman feels really good, but she's got a little bit too much estriol here. We're gonna change the ratio to 70-30 or 60-40. And you just really have to understand the intricacies of the metabolism of estrogen to be able to pick that out. And you got to do the 24-hour urine hormone test to be able to do that. Occasionally, we'll put a woman on 80-20 and she'll feel so much better, but you won't feel, I'll be listening to her and I'll go, I think there's room for a little more improvement here. And we'll test her and we'll see, oh yeah, look at that. She's got a little bit more estriol than we like to see. Let's tweak that formulation. Let's change it from 80-20 to 70-30 or 60-40 or 50-50. And occasionally we'll see a woman who is on 50-50. She feels good on it. And when it comes around, some other provider put her on it. So we don't mess with something. If the woman feels pretty good, although she may convert to the oils, it's easy for us to make a 50-50 oil. So we'll just switch to the 50-50 oil. And then when she says, hey, this is good, I feel as good as what I did on my other stuff, bravo, we're going to test you. And then we get to see if that 50-50 is the proper ratio only when we do the 24-hour urine hormone test. Because what are we trying to do in the 24-hour urine hormone test? Copy nature, as Dr. Jonathan Wright suggested to all of us. Why try and reinvent the human being or the woman? Why come up with a new formula for the ratios that appear in a young, healthy woman? We don't try and do that. So, Antoinette, to cut to the chase, it's very unlikely that you're going to see symptoms with the 50-50. You might have symptoms of too little estrogen, or you may have symptoms of too much, but that's very unlikely to be related to the 50-50. You're doing great on 50-50. The only way we're really going to tell, well, here's the symptom card, and you know that you can download this. And of course, this is in the book. So these will just tell you general overdose. But the subtleties of the difference of the ratios, 99% of the time, I'm picking them up on 24-hour urine hormone tests in a woman who's saying she's doing well. And occasionally, a woman will titrate to symptom alleviation, and she'll be doing well, but I'll get this hint inside. She could be doing better. Do the 24-hour urine hormone test. I see she needs to change her ratio. Hope that answers it for you, Antoinette. Oh, my goodness.
Yeah. I know what's coming. The hard stop. Drum roll. Dr. R, so good to see you.
You too, Carolyn.
Thank you.
Yeah.
And I am aware today is Tuesday. So that means we will see you on Thursday. And we'll get to these last two questions and certainly anything else that comes up. And I hope that you have a great day, couple days, and I hope everybody does.
Yes. Good to see you, Carolyn, and everybody else. And we'll see you on Thursday morning.
Have a really good couple of days, everybody. Many blessings.
Bye-bye now.
Bye.